Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is Introduction to Opportunistic Infections and Opportunistic Infections Central Nervous System. And the speaker is Dr. Shivani Patel, ma'am. Dr. Shivani Patel is currently working as the professor with the Department of Medicine at the BJ Medical College and Civil Hospital, Ahmedabad. We welcome you, ma'am, for today's session and request you to start the session.
Thank you. Very good afternoon to all of you. And today we are going to talk about opportunistic infections. So as you all know that HIV is a disease of immunosuppression. And as the immune system gets suppressed, it leads to the emergence of opportunistic infections. So what exactly do we mean by opportunistic infections? So as the immunity goes down, some latent infections that have been harbored in the body, they come to the fore, and that is what with the patient presents to us with. So as you all know that other than the acute seroconversion, there are a few clinical presentations of acute seroconversions. So other than that, per se, we would not have symptoms of HIV infection, but most of the times patients will present to us with symptoms of opportunistic infections. And why is it necessary to address opportunistic infections? Why is it necessary to be vigilant? I would say vigilant about opportunistic infections because if we do not have it at the back of the mind, it can be easily missed and it can often be catastrophic. So we are going to talk about an approach to opportunistic infections in general and specifically about certain CNS opportunistic infections in this session. So what are the common symptoms and signs? As I said that patients of HIV, other than in the acute seroconversion phase, there are no specific symptoms and signs of the HIV infection per se, but most often they present to us with the symptoms and signs of opportunistic infections. And it is important to identify the symptom complexes of these opportunistic infections, because when we are sitting in our outpatient department, say for instance, an immunocompetent patient presents to us with headache, the differentials would be different. If an immunocompromised patient comes to us with a complaint of headache, it should immediately lead to suspicion of certain OIs, because detection of OIs in the early phase leads to better management and decrease in morbidity and mortality. So again, symptom complexes would be specific to different systems in the body. Say a respiratory system presentation, a patient presenting with cough and breathlessness. So we think of the respiratory opportunistic infections. A patient presenting to us with diarrhea, we would think about the gastrointestinal opportunistic infection. So there are specific symptoms for specific systems in the body. We will look at those and what are the common challenges in diagnosing. So it is not so easy as we would diagnose diseases in immunocompetent patients. Sometimes the same symptom complex would be responsible for different multiple opportunistic infections. Or if we miss, say, considering a headache, if we miss the diagnosis, it can lead to more life-threatening situations in the PLHI. So we will address all this. And other than that, you can see the list of the central nervous system opportunistic infections. So there are various neurological syndromes. As you all know that HIV is a neurotropic virus, highly neurotropic virus, and therefore there are various syndromes that can occur in PLHIV, which we will see later in the session. And there are opportunistic infections. See, we had never heard of patients presenting with Cryptococcal Meningitis or Toxoplasmosis in the pre-HIV era, except for those patients who were on immunosuppression for, say, organ transplant or something like that. Other than that, we never saw these infections in the pre-HIV era. In the post-HIV era, we have been seeing these opportunistic infections like cryptococcal meningitis, toxoplasmosis, cytomegalovirus disease. Meningitis we see in the immunocompetent patients also. Again, progressive multifocal leukoencephalopathy and certain neurocognitive disorders. So there is a spectrum of diseases from asymptomatic neurocognitive or asymptomatic neurocognitive impairment to a full-blown HIV-associated neurocognitive disorder. Again, as we know that any part of the neurological axis can be affected. So it is not only the brain or the meninges that can be affected. It can also be the spinal cord or the peripheral nerves in form of neuropathies or the muscles also. And again, neurosyphilis. Say post penicillin invention, the prevalence of neurosyphilis had gone down, but again in context of HIV we need to keep this in mind. Neurosyphilis, a tertiary syphilis that we often see in patients. So we need to understand that, as I said, that opportunistic infections, basically as the name itself suggests, that whenever they get an opportunity to strike, they will strike. So these infections may have been latent in the body, they have been harbored for a very long time, but when the immunity goes down, say a declining CD4 or an increasing plasma viral load, so in those conditions, whenever there is an infection or a disease caused by a microbial agent which takes that opportunity of declining immunity, say in a person with an compromised host immune system, then that is called an opportunistic infection. So we need to understand what is the difference between opportunistic infections and full-blown acquired immunodeficiency syndrome. So acquired immunodeficiency syndrome, other than the occurrence of life-threatening opportunistic infections, there can be certain malignancies, certain neurological disorders which are not infections, and other specific illnesses in patients with HIV infection and CD4 counts less than 200 cells per cubic millimeter. So I hope you now understand what is the difference, and OI can be a part of AIDS, but the spectrum of AIDS is much wider, and other than OIs, it also includes certain other disease entities. So in 2020, our prevalence, HIV prevalence in India was something like say quantum of 23 lakhs or so, and deaths, they say about 63% of the deaths were due to opportunistic infections according to the data. So though with advent of antiretroviral therapy, so it is very clear. See, in the pre-antiretroviral era, we used to commonly see oral hairy leukoplakia. Nowadays, it has become less common. So with the advent of antiretroviral therapy, in a systematic review, they suggested a great reduction in the incidence of OIs of the extent of 57 to 91%, except for TB. TB is still prevalent. And as you know that tuberculosis, pulmonary and extrapulmonary remains a challenge in our country. And it can occur at CD4 counts even higher than 200, in the range of 200 to 500 also tuberculosis. But other than that, there has been a significant decline in the opportunistic infections like oral candidiasis, PCP. So pneumocystis pneumonias, again these days we are seeing it much less than what it used to be prior to the ART era, and toxoplasmosis. And there was a non-significant reduction in the opportunistic infections like Cryptococcal Meningitis and esophageal candidiasis after initiation of antiretroviral therapy. So it is necessary to arrive at an early diagnosis, and there should be a proper intervention, that is treating the OIs should be a priority in a patient who is detected with HIV, because again the time of initiation of antiretroviral therapy, or the patient if already on antiretroviral therapy develops an OI. So these are some of the prime concerns that we have when we are seeing these patients. Again, the drug-drug interaction should also be kept in mind. So treating opportunistic infections should be a priority. So there are certain screening protocols which we should have in mind when we are seeing these patients in our outpatient department or in the wards. So there are two things which decide the incidence of opportunistic infection. One is the level of immunosuppression. So as you all know that the normal range of CD4 would be something around 1200, like 500 to 1200. And as the CD4 count declines, and when it is below 200, you can have multiple opportunistic infections in a given patient. So level of immunosuppression is one factor deciding the incidence of opportunistic infection, and the second is the endemic prevalence of the causative agent. There are certain region specific opportunistic infections also, like leishmaniasis or penicillosis, which are not found in the whole of the country but in the specific regions. So just take a minute to look at this graph. As you can see that as the CD4 starts declining, so in the range of 200 to say 500, you find opportunistic infections like Mycobacterium tuberculosis or bacterial pneumonias or oral candidiasis in these patients. But once the CD4 drops below 200, there can be several life-threatening opportunistic infections like pneumocystis pneumonia, Cryptococcal meningitis, Toxoplasmosis, lymphomas, Kaposi sarcoma, atypical mycobacteria. So once it is below 100, the opportunistic infections that we need to keep in mind are, say, cytomegalovirus infection, progressive multifocal leukoencephalopathy, or primary CNS lymphoma. So you will see that as the CD4 declines below 200, there are n number of opportunistic infections that can strike, and therefore we have to be very, very vigilant when a patient comes to us with a CD4 cell count below 200. The pooled estimated prevalence of tuberculosis, as you can see, is the highest, of up to 56%. As against that, you can see that the cryptococcal meningitis prevalence is only 4.3%. But it is the high mortality associated with this condition that makes it a serious concern to us. Again, the common presenting signs and symptoms. See, a patient with so many opportunistic infections can present to you with fever. So whenever a PLHIV comes to you with fever, it is necessary that you devise an approach to this symptom, because it can be a plain, say, salmonellosis, to some life-threatening condition like a cryptococcal meningitis. So fever is the commonest symptom, followed by weight loss, cough, dyspnea, diarrhea. So these are the common symptoms and signs that are present in PLHIV presenting with opportunistic infections. We will see the specific symptoms with the specific systems that are related to the opportunistic infections. So what we should keep in mind? Why are we stressing so much on the diagnosis of opportunistic infections? It can be easily missed if we have not actively looked into it. So there should be screening protocols in place in every center. And those strategies will help us to diagnose the opportunistic infection. Like we have the 4S, right? The 4S for the diagnosis of tuberculosis. Similarly, certain symptom complexes like fever, headache, and altered sensorium, immediately you think about a cryptococcal meningitis, or it may be a tuberculous or a bacterial meningitis, so on and so forth. Again, as I already told you, that how to approach the management of these patients. Whether the patient is ART naive, in that condition, your priority should be to treat the opportunistic infection first. What will happen if you don't treat the opportunistic infection first? If you already start the ART, and if the immunity is boosted up, then it may lead to life-threatening IRIS, immune reconstitution inflammatory syndromes. So whether the patient is ART naive, in that case, treat the opportunistic infection first, let the patient be settled, then start ART. If the patient is already on ART, then what would be your concern? That is it an IRIS or is it a treatment failure? Okay. Again, pregnancy should not be a contraindication to treatment of any opportunistic infection, because these can be life-threatening. Again, drug interactions, because when we are administering the treatment, the chemotherapy for opportunistic infections, as well as the antiretroviral therapy, there can be drug-drug interactions which need to be kept in mind. So here are the organism-wise opportunistic list of opportunistic infections, like bacterial tuberculosis being the most common. There can be bacterial pneumonitis with Streptococcus pneumoniae, Haemophilus influenza. There can be meningitis with Streptococcus pneumoniae, Haemophilus influenza, and Neisseria. Again, Staph aureus can be another infection. Intestinal infections, Salmonella, Shigella. So a patient, say, for instance, presenting with high-grade fever, with chills, with diarrhea and abdominal pain, we would suspect salmonellosis in that patient. So E. coli, Clostridium difficile, or atypical mycobacterial diseases. Viral diseases, it could be varicella zoster, herpes simplex virus, which can lead to simple angular cheilitis, or it can be responsible for a more life-threatening, say, temporal lobe encephalitis also. Cytomegalovirus, CMV retinitis is by far the commonest presentation, but it can again affect so many parts of the neurological axis and also parts of the gastrointestinal system. HPV, EBV, again JC virus leading to progressive multifocal leukoencephalopathy. Fungal, as we all know, commonest being oral esophageal candidiasis, pneumocystis pneumonia, Cryptococcus meningitis, penicillium, which is now known as Telleromyces marnepi. So it causes penicillosis or histoplasmosis. Though histoplasmosis is not very common in our part of the world. Again, parasites, you have Toxoplasma, Cryptosporidia, Isospora, Microspora, Giardia. These are all intestinal opportunistic infections that a patient might have. So we'll talk about it when we talk about the GIOIs. Again, based on the systems affected, you have to be aware of the etiologic agent. So whenever there are symptoms related to the respiratory system, say patient presents with fever, cough, and breathlessness, with maybe constitutional symptoms. So Mycobacterium tuberculosis is the commonest cause. There can be bacterial pneumonias, there can be pneumocystis pneumonia. Again, all other organisms. As you can see that toxoplasmosis also can affect the lungs, so also histoplasmosis. So we should keep this in mind, because several of these are differentials for the miliary mottling on an X-ray also. It is not necessary that the miliary mottling be only due to tuberculosis. So whenever we are seeing a patient, we need to keep these etiologic agents in mind. GI system, again, candidiasis, HSV lesions, EBV infection leading to oral hairy leukoplakia, aphthous ulcers, and acute and chronic diarrheas. CNS, will talk about it in a while. I'm not going through the whole list. And skin and mucous membrane, again, you can see there is a list of opportunistic infections, that is etiologic agents that can lead to skin manifestations. So what are the challenges? Why it is so difficult, and sometimes we miss, or sometimes we do not get a say definitive diagnosis of the opportunistic infections. So what are the problems? In tuberculosis, again, we have the paucibacillary forms and atypical clinical presentation. There may be disseminated tuberculous infections in the patient. We have seen tuberculosis affecting so many body parts. It can be the lungs, it can be the pleura, it can be extrapulmonary, leading to tuberculous lymphadenitis, the CNS, the GI part, the skin, leading to scrofula. We have even seen in fundoscopic examination choroid tubercles in disseminated TB. So sometimes disseminated TB, the patient may present with very atypical clinical presentation, and then the sensitivity of the existing screening tests is again poor. So especially in patients with lower CD4 counts. Again, getting a good specimen. If you are suspecting an intestinal pox, then getting a good specimen for CBNAT testing would be a challenge. And all centers may not have the facility for a proper diagnosis. Candidiasis, again, if you are suspecting an esophageal candidiasis, then it has to be confirmed by endoscopy, which may not be available at all centers. Pneumocystis pneumonia. So that, again, as I said, is a subacute symptom complex of fever, cough, and breathlessness, and with arterial hypoxemia. That is what you can record. But getting a microscopic confirmation is often very difficult, and therefore, at all centers, we need to have a high index of suspicion for pneumocystis pneumonia in patients presenting with these symptoms. Cryptococcal meningitis, as I already told you, that headache may only be the presenting symptom. So if you wait for other CNS symptoms to develop, like the cranial nerve abnormalities or altered sensorium, the disease may well be in an advanced state. So if a patient simply comes with headache, we should have a high index of suspicion and a low threshold for CSF. So if you, but certain centers might not have the facility for a lumbar puncture. Again, the differentiation between new and relapsed cases, because culture testing is not available at all places, again, cultures may not yield the organism. So it becomes very difficult whether to treat it as a relapse or whether to treat it as just a persistent antigenemia. Toxoplasmosis, you need to have an MRI facility available. Again, chronic diarrhea. So even for our residents, we keep telling them that you start the patient on empirical therapy, but do send for cultures for cryptosporidiosis, isosporia, microsporidia. So again, lack of sensitization will lead to paucity of diagnosis in these conditions. CMV retinitis, you need to have an expert ophthalmologist and a fundoscopy available at the center for the diagnosis. Again, with cryptococcal meningitis, a long duration of follow-up is required. At least 1 year maintenance phase of fluconazole should be adhered to, and there are very limited treatment options, and again, non-availability of certain drugs. Like even at our center, We have difficulty in procuring flu cytosine, arabinocytes. So our say treatment protocols will include only amphotericin B and fluconazole. So this was just an overview of the approach to opportunistic infection. So by now, I think you know what is the definition of opportunistic infection, how to approach a patient, and how to have screening protocols in place. So you should be aware of the various symptom complexes that can present with the underlying opportunistic infections. System wise and etiologic agent wise, you should have it in mind. It is said that eyes don't see what mind doesn't know. So if at the back of your mind, if you don't have it, then you might easily miss an opportunistic infection in a patient. Now we go on to specific opportunistic infections of the central nervous system. So I've already told you that it's a neurotropic virus. So now there are two presentations. There are certain diseases occurring by the direct neurotropicity of the virus itself, and certain diseases which present as infections of the central nervous system. So these are the two things that will constitute your central nervous system opportunistic infections. And it is said that at least 10 to 20% of the people will have the first manifestation of HIV as a neurological symptom, and at least 60% of the patient experience some neurological symptoms pertaining to OIs in their lifetime. 60% of the PLHIV will experience that. So just take a minute to look at this list. So per se HIV related, which is not due to any specific opportunistic infection, which is not related to some say etiologic agent, specific etiologic agent, but still because of the neurotropicity of the virus, we have HIV related conditions like acute aseptic meningitis, chronic meningitis, and as I told you that ranging from asymptomatic neurocognitive impairment, that is called ANI, to MND, minimal neurocognitive decline, to a full-blown HIV-associated neurocognitive disorder, which is called HAND, HAND. Then again, you have AIDS dementia complex or the HIV encephalopathy. Vacuolar myelopathy is the disease of the spinal cord, as it suggests. Peripheral neuropathy, distal sensory polyneuropathy is the commonest neuropathy in patients with HIV, and you can have myopathies. Specific etiologic agent related or infection related diseases are cryptococcal meningitis, cerebral toxoplasmosis, CNV retinitis and encephalitis, PMLE, progressive multifocal leukoencephalopathy. A word about this PML, it is a quite common presentation of iris also, because subtle symptoms may have been missed at the time of diagnosis and ART is initiated, and then often we see patients presenting to us with PML iris, which can sometimes be life-threatening. Primary CNS lymphoma, tuberculosis and syphilis. So what are the symptom combinations, key combinations? So broadly, we look at it as a global syndrome or a focal syndrome. See, when we say global syndrome, that means there is no focal neurological deficit. So patient may present with headache, fever, nausea, vomiting, altered consciousness. Okay, so that is a global syndrome. But when patient presents with focal neurological deficits, why we need to identify these two things, the global syndrome and the focal syndrome? That is because the etiologies are different. The likely opportunistic infections can be different. Those some infections like tuberculosis can present as both. Suppose there is a tuberculous meningitis, it will present as a global syndrome. And if there is a tuberculoma, then it can present with a focal syndrome. So we have to keep these symptom complexes in mind. So headache, fever, nausea, vomiting, altered consciousness, think of meningitis. It could be tuberculous meningitis, it could be cryptococcal meningitis, it could be neurosyphilis or acute syphilitic meningitis and other bacterial meningitis. Suppose the patient has headache with a focal neurological deficit and seizures. Then think of tuberculomas, toxoplasma. Sometimes progressive multifocal leukoencephalopathy also will present with focal symptoms, and that usually is like a stuttering presentation. Say patient may have first a lower limb weakness, then after say 15-20 days, it may go on to involve the upper limb. Then the patient can have aphasia. So PML often presents like a stuttering illness. Syphilis, primary CNS lymphoma, and neurocysticercosis should be kept in mind, because all these things, tuberculosis or tuberculomas, toxoplasmosis, neurocysticercosis, CNS lymphoma, they all present as ring enhancing lesions on the MRI. So they are the differentials of ring enhancing lesions. Now, if the patient has a global syndrome like cognitive impairment, psychiatric features, so there may be an organic psychosis, altered consciousness, or seizures, then think of encephalitis. So cytomegalovirus encephalitis, HSV encephalitis, as I told you, HSV encephalitis has a predilection for the temporal lobes. Toxoplasmosis, toxoplasma encephalitis is usually an advanced disease and it is associated with high mortality. Again, patient can have sensory disturbances, paraparesis or sphincter disturbances. Then you think of a myelitis. Cytomegalovirus specifically has a predilection for lumbosacral radiculomyelitis. Okay. Herpes virus, so it can be HSV or zoster infections. They can present as acute transverse myelitis. Syphilis, toxoplasmosis, and tuberculosis. So myelitis can be present if there are signs and symptoms pointing to the spinal cord. Neurocognitive decline. So it starts with the memory loss or behavioral abnormalities, and there may be motor function deterioration, especially in the AIDS dementia complex. So it is associated with the HIV associated neurocognitive disorder. I hope the symptom complexes are clear to you. So a global syndrome, a focal syndrome, a neurocognitive impairment with seizures, or symptoms pertaining to the spinal cord, or symptoms which suggest a neurocognitive decline, they have varied etiologies and which should be suspected whenever you have patients presenting with these symptoms to you. So now we'll go into specific opportunistic infections. So it is basically an encapsulated yeast. Cryptococcal meningitis is caused by an encapsulated yeast of Cryptococcus neoformans. Geta is not so common. It is majorly Cryptococcus neoformans that is responsible for the cryptococcal meningitis. And presence of cryptococcal antigenemia is an independent predictor of cryptococcal meningitis. So now in our program, serum cryptococcal antigen has been made mandatory for patients with a CD4 below 200. It is not available at different centers. That is a different issue, but cryptococcal antigenemia. So if it is present, then it is an independent predictor of cryptococcal meningitis in patients with HIV. So less than 200 presence of serum cryptococcal antigen, there should be a high index of suspicion for cryptococcal meningitis. Again, it is associated with high mortality. They show here the estimate shows 15% of all AIDS related deaths, but in developing countries, the mortality can be as high as 60 to 70%. And that is why there should be a very low threshold for lumbar puncture in these patients. So, as I said, that patients may present with very non-specific symptoms, just a fever and headache. Advanced cases may present with altered mental status, neck stiffness, or cranial nerve abnormalities, but then the patient may already be in advanced stage of the disease. So even when the patient comes with certain non-specific complaints like fever and headache, then we have to have a high index of suspicion for cryptococcosis. So you can see, you can do a serum or CSF antigen with a lateral flow assay, or it can be confirmed by microscopy. So India Inc. preparation can detect up to 60 to 80% of cases of cryptococcal meningitis. It may be present on gram staining, but it is not so common. And culture may yield, a fungal culture media may yield the organism. However, it is difficult, more so in the setting of iris. Usually fungal culture is negative in the setting of an iris. So for a patient suspected of having cryptococcal meningitis, a prompt lumbar puncture, again, there is one more point that I will underline, is the opening pressure of CSF. Opening pressure of CSF should be up to 20, but in the case of cryptococcal meningitis, it can be more than 25 centimeters of water, which can lead to splitting headache to the patient. Patient may remain symptomatic for long, and it may warrant multiple therapeutic drainage of 20 to 30 ml of CSF at one sitting. So again, whenever a lumbar puncture facility is available, it should be done without any delay. Cryptococcal antigen assay is available. If it shows serum cryptococcal antigenemia positive, then lumbar puncture should be done without delay. If it is not available and still you have a suspicion, then we can go for a lumbar puncture with an India Inc. preparation examination, which may yield the organism in 60 to 80% of the patients. If it is not available at your center, you should refer to a higher center for appropriate investigation immediately. So look for the symptoms. Do not miss any non-specific symptoms. There may be skin lesions, and which are very much alike the molluscum contagiosum, almost similar to molluscum contagiosum. Here it is written that you have to look for umbilication for differentiation, but certain lesions in cryptococcosis may also have umbilication. So it may be very much similar to molluscum contagiosum. Serum cryptococcal antigen, I already said, is indicated in all patients with CD4 cell counts below 200, whether they have symptoms of meningitis or not. Again, screening for cryptococcal antigen and followed by preemptive antifungal therapy. So suppose the cryptococcal antigen, serum cryptococcal antigen is positive, okay, and CSF is negative, patient is asymptomatic, but however, to prevent any development of invasive cryptococcal disease, there is preemptive antifungal treatment which is recommended. So before initiating ART, patients having CD4 less than 200, if serum cryptococcal antigen is positive, then they have to be given preemptive antifungal therapy. Screening is not recommended for children because the incidence is very low. So look at this chart. CD4 cell counts below 200. Serum cryptococcal antigen is positive and CSF antigen is also positive. Naturally, we have to treat as cryptococcal meningitis. But if CSF cryptococcal antigen is negative or it is not feasible, still the patient is symptomatic, or you can go for an India Inc. preparation also, then treat as cryptococcal meningitis. But if the patient is asymptomatic, serum cryptococcal antigen is positive, give preemptive treatment before initiation of antiretroviral therapy. If the serum cryptococcal antigen is negative and patient is symptomatic, consider other causes. So evaluate for TB, meningitis, other causes. If asymptomatic, then you can start with the antiretroviral therapy. Suppose serum cryptococcal antigen is not feasible and currently it is not available also in the national program. So if the patient is symptomatic, consider evaluating for TB, go for an India Inc. examination for cryptococcal meningitis or a culture, or consider bacterial meningitis and treat accordingly. If the patient is asymptomatic, so generally fluconazole primary prophylaxis is not indicated because the incidence is very low. But when serum cryptococcal antigen facility is not available and patient is asymptomatic, then we give a primary prophylaxis if CD4 cell count is below 100. I hope that is clear. So regarding preemptive therapy, asymptomatic PL-HIV with a positive cryptococcal serum cryptococcal antigen testing, all will require preemptive antifungal therapy. Again, have a low index of suspicion and have a high index of suspicion and a low threshold for lumbar puncture in all patients who exhibit any even non-specific signs of cryptococcal meningitis. So preemptive antifungal therapy. So these are for patients who are serum cryptococcal antigen positive, where CSF cryptococcal antigen may be negative or it may not be feasible, and those who are asymptomatic. So before starting antiretroviral therapy, we give an induction phase of fluconazole 800 milligram per day for 2 weeks, followed by a consolidation phase 800 milligram daily for 8 weeks. So 2 weeks induction course, 8 weeks of consolidation phase, and fluconazole 200 milligram daily till evidence of immune reconstitution, and this should be at least for 1 year. So ART initiation should be considered only after 4 to 6 weeks after initiation of antifungal treatment. Primary prophylaxis generally not recommended because of relative infrequency, and there is data does not suggest any survival benefit. Again, we are concerned about the resistance of fluconazole, but if cryptococcal antigen test is not available, and which is not available at our centers, so for CD4 cell counts less than 100, recommended dose is 100 milligram OD. And when do we discontinue the primary prophylaxis? Patient is adherent to antiretroviral therapy, free of cryptococcal disease. Fluconazole, as I said, should be given either the maintenance phase or the secondary prophylaxis, or the primary prophylaxis should be given for at least 1 year. CD4 cell counts have come above 100 per cubic millimeter and a suppressed viral load. So now what is the treatment of cryptococcal meningitis? There are 3 regimens. We usually go with the alternative 2 because of availability of the drugs there. So first is Ampho-B, which is 1 mg per kg per day, and flucytosine arabinoside 25 mg per kg 4 times a day for 1 week. But flucytosine arabinoside, acquiring that in the market is also a problem, and it is followed by fluconazole 1200 milligram per day for 1 week. So that is the first regime. Second is 2 weeks of fluconazole 1200 milligram daily and flucytosine for total of 2 weeks. And the third or the alternative 2 is 2 weeks of Ampho-B, 1 mg per kg per day, and fluconazole 1200 milligram daily for adults. So that is again a 2-week regimen, which includes Ampho-B and fluconazole, and that is our preferred regimen as of now. That was the induction phase. So induction phase is how much? 2 weeks. Consolidation phases, fluconazole 400 to 800 milligram per day for adults for 8 weeks. So remember, consolidation phase is 8 weeks And we should always look into adherence of the patient to this regimen of consolidation phase. Otherwise, we would be looking at a treatment failure or a relapse. Maintenance phase, which is also known as secondary prophylaxis, is continued for 1 year, and fluconazole 200 milligram daily for adults. So when is the maintenance phase discontinued? Again, the same criteria that I mentioned earlier. So managing raised intracranial pressure, as I told you that if it is about 25 centimeters of water, patient may have a splitting headache. So therapeutic lumbar puncture should be done in that case. And at one sitting, you can remove 20 to 30 ml of CSF. So ideally, this should be done with a manometer attached to your spinal needle. You should have the facility of the same at your center. And our goal would be to reduce the pressure less than 20 centimeter of water, or at least by 50%. So serial lumbar punctures would be required, and the routine drugs that we use for reducing the raised ICP like mannitol do not act in these conditions. So usually the treatment would be a therapeutic lumbar puncture only. And sometimes when it is resistant, or sometimes the patient does not respond, we may consider a lumbar drain or a ventriculostomy also. So amphob, see, amphob is quite a toxic drug, and we are always concerned about hypokalemia and renal failure whenever we are instituting amphob in the regimen. So liposomal amphob would be better. Sometimes it is available in our drugstore, then they provide it, but usually we have the routine amphotericin B that we administer to the patient. So it is reconstituted into 1 liter of 5% dextrose and administered within 24 hours. So usually it is administered over 4 hours, and we can easily use a peripheral intravenous line. Given the concentration of amphob is always less than 0.1 milligram per ml of dextrose water, but we need to flush the peripheral lines with saline after every injection of amphotericin B. Again, patient should be prehydrated with normal saline with a 1 ampule of potassium chloride. We also sometimes use ringer lactate instead of this. So before 2 hours before administering amphob, we need to prehydrate the patient with oral potassium and oral magnesium supplementation also. So creatinine, sodium, potassium levels are to be done on days 0, 3, and 7. And days 0 and 7, we need to do a full blood count. Manage the febrile reactions with paracetamol, or if severe, then we can give hydrocortisone also. Relapse is a real challenge in case of cryptococcal meningitis, because, and what might be the reasons? Inadequate induction therapy. If according to body weight we have given an inadequate dose, or if due to side effects it has been prematurely discontinued sometimes, then it can cause relapse. Again, I told you, I'm underlining it again, that we have to check the adherence of the patient to fluconazole therapy in the consolidation phase of 8 weeks also. Sometimes fluconazole resistance is also there. So again, presence of CNS cryptococcomas. So what is the appearance of CNS cryptococcomas on an MRI? It is usually a moth-eaten appearance. So usually it is not like the other tuberculomas or other ring-enhancing lesions, but it will appear as moth-eaten appearance. So if there are cryptococcomas, there may be resistance to treatment, or there may be failure of treatment and a relapse. So non-adherence patient should be treated as a first episode, and advanced adherence counseling is a must in these conditions. Iris, again, there is a challenge because most of the times fungal cultures will be negative. Usually we say iris occurs between 6 weeks to months. So it can occur in weeks to months, but it can occur as late as even 1 year. So as late as 1 year also, you can have iris in case of a cryptococcal meningitis. higher CSF white cell counts will be there, and frequently it is accompanied by raised intracranial pressure. So again, it would be difficult managing the raised intracranial pressure, and multiple lumbar punctures would be required. Therapeutic lumbar punctures would be required. So other etiologies of relapse, it may be due to occlusion of the arachnoid space by granulations of the fungi. And see, it is very difficult because you cannot pick it up on a neuroimaging also. Your cultures also are going to be negative, and persistence of cryptococcal antigen in the CSF or on India ink preparation would not give you a clue whether this is the initial infection or it is a relapse. So that is really challenging, and that is why we have to be very careful when we institute the regimen for treatment of cryptococcal meningitis. So this more or less what I have talked about. This is the flow chart for the same. I'm not going to repeat it again. I've already addressed all this. So you should have this flow chart handy at your center in case you need to just check what you should do in a given patient with a suspected cryptococcal cryptococcal meningitis or a cryptococcosis. So now we'll talk about toxoplasmosis. So toxoplasmosis is caused by a protozoan, that is Toxoplasma gondii, and it occurs by eating food contaminated with oocytes of cat feces or eating the contaminated meat. And it is the most common cause of focal brain lesions. Though in our country, tuberculomas are equally prevalent, but still it is quite a common cause of focal brain lesions. And generally, the clinical disease will appear only after CD4 cell count goes below 200, and more so when it is less than 50 cells per cubic millimeter, then there is a highest risk of toxoplasmosis. So as I told you, clinical manifestations, here the patient is going to have focal symptoms. So there may be headache, confusion, a focal motor deficit like upper limb, lower limb weakness or a facial weakness with fever. Sometimes there can be only non-specific symptoms like headache and psychiatric symptoms. That is why I say that it is not easy to diagnose this. And if you don't have that high index of suspicion, you may easily miss this. Because here, see, your decision whether to go for a neuroimaging would be so critical. So in absence of treatment, what will happen? There'll be perilesional edema and there may be cortical involvement and lead to seizures, stupor, coma, and death also. So there will be multiple contrast enhancing, ring enhancing lesions in the gray matter. So remember, toxoplasma, you have lesions in the gray matter, and as against that PML, there will be lesions of white matter. So we will talk about that also, how to differentiate the two on a neuroimaging. So again, serum IgG, IgM, anti-toxoplasma antibodies are not much of help because they do not indicate an active disease. However, if it is present, then it may have some positive predictive value. PCR tests have high specificity but low sensitivity. We do not have the facility for toxoplasma PCR at all centers. Neuroimaging will remain the mainstay. Other than the symptom complex, neuroimaging will give you an idea as to whether you can see the lesions here. There are more or less large lesions in the gray matter, and there is quite a bit of surrounding perilesional edema in these patients. So patients with a symptom of headache, confusion, convulsions, stupor, weakness, focal deficits, and if they have ring enhancing lesions involving the gray matter with perilesional edema, then the diagnosis of toxoplasma encephalitis can be considered. See, that is why we differentiate. For a global syndrome, we go for a CSF, lumbar puncture, straight away. Here, if there is perilesional edema, if we go for a lumbar puncture without looking at the neuroimaging, there may be brainstem herniation and death. So, how to differentiate? Again, toxoplasma, encephalitis, and primary CNS lymphoma. To differentiate that, we need to have a PET scan or a SPECT, which can differentiate. There can be a choline peak in the malignancy, which may not be found in the toxoplasmosis. So you have to have the differentials in mind. Like if you have a progressive multifocal leukoencephalopathy, they will be diffuse white matter lesions, and which can occur in the frontal parietal lobes, or it can be periventricular or in the occipital lobes, but it will be essentially a white matter non-enhancing lesions. So they will not take up the contrast. That is how you differentiate between the two. And there will be no mass effect in the PML lesions. So management, total duration is 6 weeks. The preferred regimen, pyrimethamine 200 milligram once, followed by the dose based on body weight. So less than 60 kg and more than 60 kg. If it is less than 60 kg, the combination of pyrimethamine sulfadiazine 50 and 1000 milligram QDS with leucovorin. If the body weight is greater than 60 kg, then you have a combination of 75 and 1500 QDS with leucovorin. Again, alternative regimen, you can use clindamycin if there is unavailability of sulfadiazine. Then you can use pyrimethamine plus clindamycin 600 milligram TID or QDS. Or you can use a trimoxazole combination, trimethoprim, sulfamethoxazole combination, 5 mg per kg and 25 mg per kg. So whenever we have a problem in procuring pyrimethamine sulfadiazine, we can go with the Septran 5 mg per kg and sulfamethoxazole 25 mg per kg IV or per oral twice a day. Chronic maintenance therapy again would be pyrimethamine 25 to 50 milligram OD as per body weight with sulfadiazine 2 to 4 gram daily in divided doses with leucovorin to avoid any bone marrow toxicity or folate depletion. Alternatives, you can use clindamycin and pyrimethamine combination also, or trimethoprim sulfamethoxazole double strength 1 tablet BD. So patient who has successfully completed initial therapy and remains asymptomatic and a CD4 cell count with more than 200 for more than 6 months. So 2 samples 6 months apart, then you can think of discontinuing the chronic maintenance therapy. Prophylaxis, either as primary prophylaxis. So CPT prophylaxis will protect from pneumocystis pneumonia also, toxoplasmosis and other bacterial diseases also. So double strength tablet once daily of cotrimoxazole is the preferred regimen, and if it is not available or if there is hypersensitivity reaction, you can give Dapsone 100 milligram daily. Cytomegalovirus CMV. So as we know, commonest presentation, it's a double-stranded DNA virus of the herpes virus family. And end organ damage, commonest would be retinitis, but it can cause esophagitis, colitis. So sometimes patients coming with a retrosternal pain or retrosternal severe pain, odynophagia, burning. So we need an endoscopy based diagnosis because it could be esophageal candidiasis or it can also be a CMV esophagitis. So it can cause colitis, esophagitis or CMV encephalitis. And as I said that it has a predilection for lumbosacral radiculomyelitis also. So most clinical diseases will occur when the CD4 goes below 200. And CMV retinitis may remain asymptomatic or go on to cause partial or total blindness in 1/3 of the patient. So it's a vision threatening disease. Again, you need to have a good ophthalmological setup for an early diagnosis and for appropriate treatment of the same. So patient may just start with say floaters or scotoma or peripheral visual field defects, and the spectrum or other end of the spectrum would be total loss of vision also. And on a fundoscopy, it is seen as a fluffy yellow-white retinal lesions with or without intraretinal hemorrhages. So in absence of ART or specific anti-CMV therapy, it will progress very rapidly in 2 to 3 weeks, and it may threaten the vision. It can cause blindness. Colitis occurs in 5 to 10% of patients. And again, weight loss, anorexia. So again, you see that the symptoms may be very non-specific, but sometimes patients can have debilitating diarrhea or even bloody diarrhea. So patients presenting often with bloody diarrhea, a left iliac fossa pain, abdominal pain, weight loss, anorexia, you have to keep in mind the diagnosis of CMV colitis. And if it causes perforation, then there can be acute abdomen. Again, you need an endoscopic diagnosis for the same. Esophagitis, I've already talked about it. If there is odynophagia, and again, it's an endoscopic diagnosis. Neurologic disease, patient can have dementia, ventriculoencephalitis, or polyradiculomyelopathies. Not exactly like there can be a paraparesis and a GBS looking like syndrome, but there is urinary retention and a progressive bilateral leg weakness in these patients. So if the CD4 cell count is less than 100, then have be vigilant about all these symptoms. As you can see that a single etiologic agent, that is CMV, can affect the CNS, can affect the GI tract, can affect the retina. So we have to assess these patients for visual acuity, refer to the ophthalmology department if necessary. Again, it requires specific diagnosis like ophthalmoscopic examination for CMV retinitis or an endoscopic examination for the GI disease. Again, antigen detection or culture or PCR is not recommended in these patients. And CSF, the same picture of CSF you can see in multiplicity of opportunistic infections. That is a lymphocytic pleocytosis, low to normal glucose, or a borderline elevated protein. Management, again, it should be treated for 3 to 6 months, and we should make sure that the lesions have become inactive and CD4 cell count is more than 100, at least for a 3 to 6 months period in response to ART. Regular ophthalmic checkup is required for patients who have had CMV retinitis. So valganciclovir 900 milligram orally, BD for 14 to 21 days, and then OD till the CD4 has risen, until the disease symptoms have resolved. Okay. Ganciclovir injectable 5 mg per kg for 14 to 21 days, and then 5 mg per kg, but it would become cumbersome because taking this IV daily for 3 to 6 months would be very cumbersome. So we can combine it with valganciclovir once the patient is settled and once the oral absorption is good enough for the patient. Foscarnet is an alternative, 60 mg per kg 8 hourly for 14 to 21 days. Only the CNS, CMV encephalitis, the role of oral valganciclovir has not been established, but for CMV retinitis and GI CMV infections, we can combine ganciclovir therapy or a foscarnet therapy, and later on switch over to valganciclovir. This I've already mentioned. Again, there is role of intravitreal ganciclovir also in these patients, and we have patients treated with ganciclovir implants also, retinal implants also. So specific antiviral therapy should be continued for 3 to 6 months at least. If it is immune recovery uveitis or iris, then periocular corticosteroid or a short course of systemic steroid should be considered. The same regimen is recommended for CMV, esophagitis or colitis. Neurological disease, as I said, the role of oral valganciclovir has not been established. Again, the exact duration of treatment has also not been delineated. So you have to go clinically as to how much, for how much duration does the patient need therapy. CMV pneumonitis, again, use of IV ganciclovir or IV foscarnet could be a reasonable option. Briefly about meningitis. So the cause of meningitis may be tuberculous, cryptococcal, aseptic or bacterial meningitis. This term, aseptic meningitis, in the setting of PLHIV. So it can be due to HIV itself. Aseptic meaning the total leukocyte count will not exceed 500, and it would be usually low, a low leukocyte count. So it could be due to viral infections or mycobacterial infections also. In the setting of iris, also non-infectious iris also, you can have aseptic meningitis in these patients. And again, the symptom complex may be very non-specific, like headache, malaise, fever. Sometimes patients will develop neck stiffness or photophobia, and skin eruptions may be present in these patients. So lymphocytic pleocytosis of not more than 500 cells with a normal or very mildly elevated protein and normal glucose concentration and negative bacterial antigen test. This term is called aseptic meningitis. Bacterial meningitis, we have all seen patients. We see bacterial meningitis in immunocompetent patients also. Streptococcus, Haemophilus influenza and Neisseria meningitidis are the causative organisms. Again, symptoms, they present within 1 week of infection. If ignored, then it can go on to a life-threatening disease. The cell count may range, CSF cell count may range 100 to 10,000 also. So it may go in thousands also. Protein is elevated beyond 100 mg%, and glucose would be decreased to less than 40 or less than 50% of the simultaneous blood glucose, random blood glucose. So you can get a gram stain and a CSF culture examination. And empiric antibiotic would include third generation cephalosporins, that is ceftriaxone, in a meningitis dose or in a neuro dose, that is 2 gram BD, with vancomycin 15 to 20 milligram per kg every 8 to 12 hours. Alternatively, we can use penicillin or ampicillin, but with the advent of cephalosporins, we usually prefer giving cephalosporins and vancomycin for a 10 to 14-day course. Tuberculous meningitis, again, the same symptoms, non-specific symptoms or symptoms of meningitis sometimes may present with cranial nerve palsies, pseudo-sixth nerve palsy, seizures, hemiparesis. Sometimes it may be associated with a tuberculous vasculitis, and patient may present with hemiparesis also. So CSF pressure again is high, proteins are increased, sugar is low. There will be a lymphocytic predominance in the cell count. So anti-tuberculous treatment with the standard regimen as per the TB program, and we have to give steroids in the initial phase to reduce the likelihood of obstructive hydrocephalus and vasculitis in these patients. So this is the same thing, the different, the picture, the CSF picture has been given here, and what specific investigation. So always when we are suspecting a tuberculous meningitis, we tell our residents that send for a CSF CBNAT also, and we send in a Falcon tube for drug susceptibility testing also in patients with HIV. Syphilis, again, you would find a lymphocytic predominance mildly elevated only, and protein would be slightly high. So CSF VDRL may be positive in these cases. I think I've gone a little bit overboard, but this is an extensive topic, so I'll take maybe 5-10 minutes more. PML, progressive multifocal leukoencephalopathy. So it's caused by a neurotropic human polyoma virus called John Cunningham virus. That was the first patient after which it is named. And immunosuppression in the setting of HIV will reactivate this virus. So as I told you, these are not actually acquired patient to patient. They are harbored in the body, and in the setting of an immunosuppression, they will come to the forefront. So PML occurs in patients treated effectively with ART, and in that case, you should have a high index of suspicion for iris in these patients. So there may be focal neurological deficits. As I said, it can be stuttering, that a left lower limb say weakness, and then after 15-20 days involvement of the face or the upper limb. So it can be insidious in onset with a steady progression. It can involve different brain regions. I've already told you which. And there is demyelination. It is usually the white matter that is involved. So PML is sometimes mistaken for an evolving stroke, but stroke is acute onset. PML is an insidious onset. So it is bright on a diffusion weighted T2 MRI. Headache, fever are not characteristic of PML. So lesions, hyperintense on T2 weighted and dark on T1 weighted, no mass effect and no contrast enhancement will be seen. To confirm the diagnosis, CSF, PCR for JCV DNA can be done. See, you can see this, the frontal, parietal lobes, the occipital lobes are involved with the periventricular region, and it is essentially the white matter that is involved. There is no effective antiviral therapy. So ART is the treatment of choice. Preservation of immune function should be considered. So high plasma HIV RNA is associated with a worse prognosis. Very briefly about the HIV related neuropathies. Sorry, before that we will go to the HIV associated neurocognitive disorders. So as I said, it is a spectrum of disease. So if you do a mini mental scoring, or there is something, a brief scale called HIV/AIDS dementia scale also. So wherein the recall is tested and registration is tested, there may be tests of calculation, or there may be tests of coordination. So all this is tested in a mini mental, Polstein mini mental status examination. So there can be a very subtle subclinical decline in cognition, which is called asymptomatic neurocognitive impairment. And the other end of the spectrum is HIV associated dementia. So with a significant decline in the cognition and a severe impairment of the daily routine activities. So it is more likely with a CD4 less than 200. On an MRI, see, you can see the MRI. There is marked cerebral atrophy and there is hydrocephalus. This is known as ex vacuo hydrocephalus. So due to the marked cortical atrophy, there will be presence of hydrocephalus also. And ART is the most effective treatment. Again, ARTs with a high CSF penetration score like zidovudin or abacavir, nevirapine, lamivudin, or tenofovir. These are the antiretroviral treatments with a high CSF penetration score, so which should be considered in these patients. Vacuolar myelopathy. So there is vacuolization of myelin sheath and foamy accumulation of foamy macrophages and microglia. So this causes a spastic paraparesis. So progressive leg weakness with spasticity with dorsal column involvement. So there is sensory ataxia, urinary frequency urgency, and erectile dysfunction. So CSF analysis should be done to rule out the other infectious causes. and there will be a hyper intensity noted in T2 weighted imaging in the MRI spine, specifically in the thoracic region, which is non-contrast enhancing. Primary CNS lymphoma associated with the Epstein-Barr virus and occurs when the CD4 count is less than 100. So again, patients may present with lethargy, confusion, impaired memory, headache, seizures, or focal weakness. There may be sometimes cranial nerve involvement or ocular involvement also. So the site is periventricular and there'll be irregular lesions which appear solid on enhancement. And there is prominent edema also. So as I told you, that again, there is a close differential between toxoplasmosis and primary CNS lymphoma. So you need to do a toxoplasma IgG. If it is negative, then the diagnosis is more in favor of a primary CNS lymphoma. Again, we can go for PET and SPECT scanning to again determine or to get a definitive diagnosis. Coming to the neuropathies. So there is distal symmetric polyneuropathy, mononeuropathy multiplex, CIDP, chronic inflammatory demyelinating polyneuropathy, and progressive lumbosacral polyradiculopathy, which is CMV associated. So the risk factors would be an old age, say alcoholics per se may develop neuropathies, again advanced diseases or neurotoxic drugs. Now we don't use them anymore, stavudine or didenosine, but these were quite frequently associated with neuropathies. Again, we need to rule out diabetes. So paresthesia is the commonest symptom, and there will be lower limb involvement, which can extend up to the thigh, or a glove stocking sort of a presentation. It is a neuropathy, so we expect the jogs to be diminished or absent. And again, there is dorsal column involvement. There will be diminished vibratory sensations and increased threshold to temperature and pinprick. So we can treat with pregabalin or amitriptyline, but there is no specific treatment. Talking about neurosyphilis, so there can be an asymptomatic CNS involvement, or there can be acute syphilitic meningitis. This generally neurosyphilis is a tertiary syphilis, but acute syphilitic meningitis can be present with the secondary syphilis also. So patient may have a maculopapular rash, and with that also patient can present with a syphilitic meningitis. So there may be involvement of cranial nerves 2, 6, 7, or 8. Again, meningovascular neurosyphilis can occur a few months to even as long as a 10-year period after the primary infection. So signs and symptoms, personality change. So there is something called general paralysis of insane, and their patients may have delusions of grandeur. Again, ataxia, stroke, bladder incontinence, these might be the presenting symptoms, hearing loss and seizures. CSF, so we need to do a CSF VDRL here. There may be presence of CSF pleocytosis and mildly elevated protein. Treatment is benzathine penicillin, 4 million unit IV every 6 hours for a period of 10 to 14 days. And follow-up depends on the initial CSF findings. So we might have to do multiple CSFs also to see the response. Again, retreatment should be considered if the CSF white blood cell count does not decline even after 6 months and does not normalize after 2 years. So you can see that it is a long follow-up that is required in these patients. So thank you. I hope you have got the basic idea as to when to suspect the opportunistic infections and how to have a basic approach. You should know when to suspect and what management approach, investigational and management approach you need to have, and when to refer to a higher center, because delay in diagnosis of opportunistic infections can increase the morbidity and mortality. Thank you.
Thank you so much, ma'am, for facilitating this session. Any questions from the participants? Please feel free to put in the chat box, so you can also unmute your mic. Ma'am, there are no questions. Thank you so much. The next session will be held on Monday, that's 27th of March, and the session topic is HIV and OI respiratory systems. For that, you can refer to chapter number 4.3 of the National Guidelines for HIV Care and Treatment. The feedback poll is now visible on your screen. There are 4 questions in all. Please scroll through all the 4 questions and answer them. Thank you to all the participants for patient listening. Kiran sir, we can end the poll now and conclude the session. Thank you.